In this demonstration, we will see the mechanical compression methods for the management of PPH. But before going for the procedures, I will tell you two important things in the management of PPH. Number one, active management of third stage of labor is very important, and if you are doing AMTSL in all the deliveries, then you can prevent chances of PPH by 66%. And the second important thing to remember is that the PPH management box should be ready in your labor rooms with all the items for the management of PPH. Okay. So, active management of third stage of labor you have already seen in the previous demonstration of normal delivery, AMTSL and ENBC. Now, I will proceed with the different scenarios of PPH after delivery. I am conducting the delivery, my delivery tray is ready. So, I have conducted the delivery, baby is out, I have kept the baby on mother's abdomen, dried the baby, baby is absolutely fine, crying baby. So, I have handed the baby to the mother and asked mother to start breastfeeding. Okay. At the same time, I will feel the second baby, and after ruling out the presence of second baby, I will give 10 international unit of oxytocin intramuscularly. After this, I will feel the cord pulsations. Once the cord pulsations have stopped, I will clamp and cut the cord. This is known as delayed clamping and cutting of cord. This is very important, as you all know. After clamping and cutting the cord, I will do controlled cord traction during contractions. Okay. So, this is very important that these control cord traction, that is CCT, should be done during contraction. I will hold the cord near the perineum, apply the traction like this on the cord. Simultaneously, I will do counter traction over the fundus of uterus, and during contraction I will do control cord traction. But while applying traction, I see that cord is receding back. That means the placenta has not been separated. Okay. So, I will leave this, wait for the second contraction to come. With the second contraction, I will do this control cord traction again, but again I see that the cord is receding back. So, I will try this control cord traction during contractions, and 15 minutes have passed. So, I should get alert that there is something wrong with the placenta, that it is not separating. So, I will do again the control cord traction during the contractions, and now 30 minutes have passed, still the placenta is not delivered. This is a case of retained placenta. So, this is a cause of PPH, retained placenta completely or incomplete placenta with remnants of some bits of placenta. This is a cause of PPH. This is first situation of PPH, that means retained placenta. Okay. And the management here again is communication with the mother, start 2 IV lines, one with saline and second with 100 ml of ringer lactate with 20 unit of oxytocin at the rate of 40 to 60 drops per minute. And while starting the drip, take sample for grouping cross matching and complete blood count and some other organ function tests. Okay. So, this is one scenario where the placenta is retained. Now, we will move towards the second scenario. I have delivered the baby on mother's abdomen, baby is absolutely fine, I have dried the baby, it is a crying baby. I have given this baby to the mother for breastfeeding and did delayed cord clamping. After delayed cord clamping, I am trying to do control cord traction to remove the placenta. So, with 2 or 3 contraction, I see that when I am applying this traction, there is lengthening of cord. This shows that placenta is getting separated, and when I see that placenta is visible at the introitus, I will hold the placenta in between 2 hands and rotating it clockwise or anti-clockwise, I will remove it completely with the membranes and put it in kidney tray. After this, I will massage the uterus, since the placental bed is raw. When I am massaging the uterus, I am seeing that uterus is absolutely relaxed and there is heavy bleeding. Immediately, I will hold the placenta and check for completeness. Maternal surface, all the cotyledons are together. On the fetal surface, everything is fine. The membranes, they are intact. So, placenta is complete, but still uterus is relaxed. I will see for any tears. There are no tears, but still there is heavy bleeding. So, this is a case of atonic PPH. So, for the management of atonic PPH, first I am massaging the uterus. This is number 1 immediate step. Second, even after massaging uterus, still uterus is relaxed, then start 2 IV lines with wide bore cannulas, 14 and 16 gauze. From one side, start normal saline with full speed, and on the other side, start 20 unit of oxytocin in 1 liter of ringer lactate at the rate of 40 to 60 drops per minute. And while starting IV line, remember that you collect sample for grouping cross matching and some other tests. So, I have started injection oxytocin drip and felt the uterus is still relaxed. So, here we can give injection tranexamic acid and other utotonics like injection carboprost, injection methyl ergometrin and tablet misoprostol. Okay. So, you can try these utotonics one by one and feel the uterine tone. If still uterus is relaxed, then mechanical compression methods can be given for atonic PPH management. Okay. These compression methods are bimanual uterine compression, external aortic compression and condom balloon tamponade. So, we will demonstrate the 3 procedures one by one. First, I will demonstrate bimanual uterine compression. For bimanual uterine compression, there are pre-procedure task, then the procedure and then post-procedure task. In the pre-procedure task, it is very important, since you are inserting your hand into the vagina, so it causes discomfort to the woman. So, it is very important to communicate with the woman. And second, you need long elbow length gloves, since you are putting your hand inside the vagina. Third, this is an indication for antibiotic. So, you give the first shot of antibiotic, ampicillin, gentamicin and metronidazole. Oxytocin drip is still running and bladder should be empty. So, you catheterize the bladder, and since this is an emergency and you need monitoring after the procedure, so it is better to put self-retaining catheter, that is Foley's catheter, so that you can maintain the charting of intake output. Okay. But if you insert Foley's catheter, remember that do not inflate the balloon of catheter. Just put the catheter in the bladder and leave it for continuous drainage and fix it over the thigh. So, this is for bladder drainage. Okay. So, after these are pre-procedure tasks. So, I am communicating, आशा बेटा ऐसा है, बहुत कोशिश करी कि बच्चेदानी की मालिश करके दवाइयाँ दे करके कि खून कम जाए, तो बच्चे को दूध भी पिला रही है, इससे भी दवाई निकलती है एक जो बच्चेदानी को सिकोड़ती है और खून कम होता है, लेकिन बेटा खून बहुत जा रहा है, तो मैं थोड़ा सा ना अंदर हाथ डाल करके दोनों हाथ से मिला करके मालिश करूँगी बच्चेदानी का, थोड़ा सा दर्द होगा बेटा, है ना? ज़्यादा दर्द तो नहीं होगा? नहीं बेटा, ज़्यादा कोशिश करूँगी आपको कम से कम तकलीफ हो, ठीक है, लेकिन उससे बहुत फ़र्क पड़ता है. ठीक है डॉक्टर. ठीक है. और अभी मैं छोटे अस्पताल में हूँ, तो हो सकता है मुझे आपको ये सब करने के बाद थोड़ा खून कंट्रोल में आ जाए तो बड़े अस्पताल में भी भेजना पड़ेगा, बिकॉज हमारे पास इससे ज़्यादा सुविधा नहीं है. ठीक है. आफ्टर एक्सप्लेनिंग द प्रोसीजर टू मदर and arranging the PPH management box and putting the catheter for the bladder drainage, now I will move towards the procedure. So, for bimanual uterine compression, as you know, long elbow length gloves are required. So, these are the gloves available with the mannequin, but you can prepare these gloves if you are not having it. So, you can prepare from the normal sterile gloves which you have in your labor rooms. Okay. So, I am having this long glove. Now, take the sterile cotton swab with antiseptic solution and clean the perineum from above downward. Throw the swab in the dustbin. Now, separate the labia. Insert your hand like this with finger inside, and while reaching into the anterior fornix, make a fist like this. And with this fist in the anterior fornix, now you are compressing the anterior wall of the uterus. Okay. So, fist like this in the anterior fornix. Now, with the second hand, go towards the posterior surface of the uterus and make it anteverted and press the uterus in between your two hands. While pressing, you feel the tone of the uterus. If it is getting harder, that means uterus is contracted now. Then remove your abdominal hand first, see the condition of bleeding. If the bleeding is controlled, then you can remove your vaginal hand. But after removing your abdominal hand, if you feel that there is increased bleeding, then put your abdominal hand again over the uterus and compress the uterus in between two hands. Once you are sure that the bleeding is controlled after removal of the abdominal hand, then and then only remove your vaginal hand. Okay. Now, uterus is well contracted and bleeding is controlled. Once you are sure that bleeding is controlled, take out your gloves, throw this in red dustbin and clean the perineum and apply perineal pad. This is procedure, and since you have inserted bladder catheter, but not inflated the balloon, now you inflate the balloon of the bladder catheter and connect it with urobag. Okay. So, this is complete procedure. After the procedure, the post procedure tasks are that monitor vitals every 15 minutes for the first 2 hours. Again, oxytocin drip should be continued. Antibiotics should be given as per the schedule, and look for the contraction of the uterus and the bleeding PV. If everything is controlled, then this case is managed with bimanual uterine compression. If still you feel that uterus is still relaxed, other mechanical compression methods can be used, or out of these 3 compression methods, in which procedure the provider is comfortable, provider can use that compression method. Maybe she can directly go towards external aortic compression first, or maybe she can use condom tamponade first. Okay. So, there is no priority as such, but which procedure should be done first. Okay. So, I have demonstrated bimanual uterine compression. The second compression method for management of atonic PPH is external aortic compression. See, for external aortic compression, the basis for this is that you are compressing the aorta at the level of umbilicus just above the fundus of the uterus before the bifurcation of the aorta into 2 common iliac arteries, so that the bleeding going down towards uterus and legs gets stopped when you are pressing the common abdominal aorta. Is it clear? So, this is a temporary method, and meantime, since this is an emergency and you have called your team member, so the other team members meantime can do the procedure from lower down. Maybe they can put condom tamponade, or if there are tears, they can stitch the tears. And once the person who is doing abdominal aortic compression is sure that bleeding is controlled, then the person can take out his hand. Okay. Now, I will demonstrate external aortic compression. For external aortic compression, I need to go towards left side and stand on the footrest. So, for external aortic compression, the provider should stand on the footrest above the level of the examination table or labor table, and the hand position for compression should be like this. You make the fist like this with thumb outside, and with this flat off metacarpals apply pressure over the abdomen. Feel the height of fundus and just above the umbilicus put pressure like this. Simultaneously feel for the femoral artery pulsations. Apply pressure deeply till the pulsations in the femoral artery stop. The pulsation stops means the blood flowing down has been stopped, and simultaneously your other team members can do some procedure lower down, maybe applying condom tamponade or suturing. Once you are sure that the bleeding is controlled, then and then only remove your pressure from the abdomen. Okay. So, this is a temporary procedure. This is not a treatment of PPH, this is just a temporary procedure so that your other team members can control the PPH. Till then you have stopped the bleeding from uterus. So, this was procedure for external aortic compression. Now, I will demonstrate the third mechanical compression method, that is condom tamponade. For this, I am using this mannequin known as Mama U, and the items required are sponge holding forceps, PPIUCD insertion forceps also known as Kelly's forceps, Sim speculum, sterile thread, this is catgut, plastic cord clamp, bowl with sterile cotton swabs, condoms, IV set, Euro bag, self retaining catheter, that is Foley's catheter, scissor to cut the thread, and this is normal saline bottle, and this is antiseptic solution bottle. So, since we all know that this is an emergency and the whole team should work to manage the case. So, I have called my team member and she will assist me in this procedure. To begin the procedure, there are some pre-procedure tasks and then procedure and some post-procedure tasks. Pre-procedure tasks are, one is communication with the client. This is very important and this is a component of respectful maternity care. Second is, bladder should be empty. So, put a catheter, self-retaining catheter, and completely drain the bladder and fix with Euro bag. The third is, continue 20 unit oxytocin drip. Fourth is, give first shot of antibiotics. And fifth one is, your item should be ready. So, these are pre-procedure tasks, and now I am doing the procedure. For this procedure, I need my team members' help to prepare the IV set. And simultaneously, I will prepare the condom over the catheter. insert the catheter into the condom, leave the tip, and the end of the catheter should be tied with a sterile thread. Remember that when you tie the thread should not be too tight and should not be too loose. So, the catheter with the condom is ready and here the IV set is ready. Now, I will start the procedure. Retract the posterior vaginal wall with sim speculum. With sponge holding forceps, clean the cervix with antiseptic solution. Hold the anterior lip of the cervix. Now, hold this catheter with the PPIUCD insertion forceps, and the procedure is absolutely same as you are doing PPIUCD insertion. Okay. So, insert the catheter like this, straighten the uterus and go till the fundus, leave the condom there and bring the forceps out. Now, connect the end of the IV set with the drainage portion of the catheter. And start pushing. Start pushing normal saline with this drip. In Mama U model, this is a useful point that you can see the inside of the uterus. See, can you see the condom filling with saline? See, this is inflating. Can you see this is inflating? Now, push the saline around 300 to 500 ml and simultaneously feel the contour of the uterus. If the uterus is well contracted, you feel the uterus is well contracted and the contour, you can see the shape and contour of the uterus, that means the uterine cavity is filled with saline. Okay. Once you are sure that this is filled, then clamp this catheter and remove the IV set. Leave this in place for 15 minutes and see the status of bleeding. If bleeding is controlled, that means your procedure is successful. Okay. Once you are sure that bleeding is controlled, then apply this plastic cord clamp instead of this steel one. and remove the steel clamp and fix this catheter over the thigh. Now the woman can be ambulatory, woman can move around. There is a catheter in the bladder and there is a catheter filled with saline in the uterus. Now make a contour, you make a mark with a pen over the contour of the uterus, and this was the procedure. Now leave this filled balloon for 12 to 24 hours. So after completion of this procedure, now we will move towards post procedure tasks. In this, we monitor vitals every 15 minutes for the first 2 hours and then every 30 minutes for next 3 to 4 hours. Maintain intake output chart. Oxytocin drip should run. Antibiotic will be given as per schedule. Check for the bleeding and check whether the contour marked over the abdomen is maintained. If it is going beyond the pen mark, this shows that there is blood collection behind the condom tamponade. So it should not be there. Okay. So contour should be maintained, and these are post procedure tasks. After 12 hours, if everything is stable, the mother's condition is stable, bleeding is controlled, then deflate this condom, take out 200 ml of saline, clamp the catheter again and watch for 1 hour again. If after 1 hour you see that bleeding is controlled, then again remove next 200 ml of saline. But once you have removed 200 ml saline and you saw that bleeding is not controlled, then again connect this with IV stand and push the 200 ml again and leave it for 12 hours. Okay. So if the bleeding is controlled, gradually take out all the saline and then remove the complete unit. See the condition of mother. Mother is stable, uterus is well contracted and bleeding is controlled. So this was the procedure of condom tamponade. This is very simple procedure. The condom tamponade can be prepared with all the items easily available in the labor room. And this is very effective procedure in controlling atonic PPH.